So thank you again, Dr. Gluck, for the gracious introduction and the opportunity to share with each of you today. So the title of my talk is Examining African Americans' Risk Factors and Susceptibility for Alzheimer's Disease. I do have some disclosures which are listed here on the screen, and if anyone would like to ask me questions about those disclosures, I'm happy to answer them following the talk during the break period. So our objectives today is that we are going to review the epidemiology of ADRD. We're going to be using ADRD throughout this presentation as an acronym. And then we're also going to be talking about willingness, which is determining the actionable steps that we can take to increase health equity. And if you notice, my learning objectives are an acronym as well now. So now is the time for us to make a change. So I'd like to start with a quote from one of my favorite authors, Audre Lorde. In our world, divide and conquer must become define and empower. So for us, now we have the opportunity to think about what has happened in the past in terms of the definition of ADRD as it impacts the African American community and the African diaspora. We also have the time is now for us to think about actionable steps we can take for prevention, primary and secondary prevention, as well as tertiary prevention, to make sure that we are able to increase wellness. So when we think about the epidemiology of Alzheimer's disease and related dementia, this chart comes from, and I'm sure Dr. Hill will be speaking about this later today at 3:40, actually comes from the Facts and Figure report. And as you can see from this report, this has the projected increase of Alzheimer's disease by 2025. And guess what? That's not that long from now. You know, that's right around the corner. So that means that people that are projected to be at risk for Alzheimer's disease and related dementia probably were showcasing symptoms 20 years prior to diagnosis, right? So that means that we have to really start thinking earlier. And much of our federal funding that we receive in this space usually only provides funding for us to do research on people that are 65 and older, 45 and older, which means then that we're not able to do some of the primary prevention work that we also want to do. So aside from being an epidemiologist, I'm also a health educator. So thinking about that health education, health promotion aspect of prevention. And then as our previous speaker spoke about the slave trade, we can see from this map the areas that are greatest risk are areas that were probably mostly impacted by the transcontinental slave trade, which are the areas down in the South. So look at Florida, look at Alabama, look at Mississippi, and things like that. And as you go up the coast, you can see other areas impacted as well. And you can also trace migration patterns as well in terms of the proposed increased risk of ADRD. So I don't think that we can really start talking about the African American experience without having a conversation a little bit about what is race. So race in the United States is very different than what you will find in other places. So this slide here showcases our current racial categories that we have according to the United States Census. And as you can see, all of this is based on self-identified characteristics. And we know that race is a social construct. It is not a genetic factor, right? And a lot of times in research, we want to try to impose genetics on this, but it's really a social construct for counting that came about in the early 1800s when the census were being collected to see who were free and who wasn't. So if we take that into consideration, we know that these categories are not inclusive of who we see how we see ourselves necessarily. So there is a debate at the end of this month. There is a group that has proposed changing these categories and looking at, instead of just self-identified race and ethnicity, but looking at ethno-racial categories for the census, which means that there will be more categories and more of an opportunity for people to really be able to describe themselves in terms of how they see themselves, not just based on these 5 categories and one ethnic category. So I'm not sure if it's going to pass, but we'll see. So this quote here is from Dr. Francis Collins, who I'm sure many of you all have heard of. He used to lead the NIH. And I like this quote. He was pioneering in the Human Genome Project, because it really talks about race being a proxy measure for other things. And if we think about race being a proxy measure, that means then that there are other factors that are putting, especially communities of color, at greater risk for Alzheimer's disease and related dementia. So we think about things like the social determinants of health and how that plays a role in whether or not we have access to care, whether or not we have access to the proper diet. As our speaker earlier spoke about the fact that the diet within the African American community is higher in fat versus the diet in Nigeria, and how all of those play a role in ADRD, especially vascular dementia. So what about the epidemiology of ADRD in the African American communities? So non-Hispanic blacks and Hispanic older adults are more likely to have an ADRD diagnosis than our white counterparts. African Americans are twice as likely to be diagnosed with Alzheimer's disease and related dementia. And there are some differences in the influence of APOE4 ally on Alzheimer's disease risk appearance for white Americans than for black Americans. But race, again, is a social construct. So these differences do not always account for all differences that increase African Americans' risk for ADRD. We know that Medicare recipients who are 65 and older are often diagnosed with ADRD more frequently in terms of them being black older adults, followed by Hispanics. And we know that the influence of ADRD in these groups also sheds light on why blacks are more likely to have a diagnosis, and we're also more likely to have more advanced disease. And that goes back to access to care, that goes back to availability of resources, that goes back to opportunities that we have in terms of being able to be believed and heard when we do have symptoms, and also the ability of us to have access to referrals to neurology for proper diagnosis. So again, I like quotes. So here's another one. This is from Desmond Tutu. My humanity is bound to yours, for we can only be human together. So if we think about that acronym now, we now have an opportunity to really think about how social determinants of health experienced by African Americans play a risk factor for ADRD. So it goes back to looking about the timeline of racism. And y'all, I don't shy about talking about racism. I can tell you my personal and lived experience as a black woman experiencing racism. So those that say that racism doesn't exist, come talk to me about how I've been called the N-word walking down the street recently, and how people that I love have not been able to access care that they need for ADRD because they were not heard by their healthcare providers who were not racially concordant. So we think about that, and we think about the timeline of racism in science and how this plays a role in even us having the ability to recruit people for our trials. We live in the shadow of the untreated syphilis experiment in the Negro male. We live in the shadows of Henrietta Lack. If we don't honor the past by saying that these were unethical, and even in St. Louis, we live in the shadow of the Cold War experiments, which were done where they sprayed like y'all remember that thing called Roundup? So that was created in St. Louis at Monsanto, which is now Bayer. So some of those companies were doing experiments with spraying vegetation for chemical warfare in areas where black folks live. No one asked. No one said, should this be done? But yet, the remembrance, and even those communities, because this happened in the 50s and 60s, are still living. You know, those members of our communities are in their 70s and 80s, and many of them now have diagnosis of comorbid health conditions, which then increases their risk factors for Alzheimer's disease. So in the 1700s, this was then the first description of race, of man, came about. The theory of craniotomy was also invented in the 1800s, which looked at cranial size, and there were thoughts that a slave or an enslaved black person's crane or skull was smaller than their white counterparts or their slavers, which was untrue. Eugenics also came about in the early 1900s, but as recently as 2014, an article came out that looked at, in the New York Times, by a journalist by the name of Wade, who argues that race-based science is troublesome. It's a troublesome inheritance. However, many people still do race-based science without thinking about racism as a construct that impedes our ability to sometimes have the things that we need to be healthy. Right? So we can talk about redlining, we can talk about grocery stores and hospitals closing. In St. Louis, where I work, I'm actually in my hometown. And so I think about the fact that the hospital for the poor and uninsured that existed when I grew up is gone. And that's in the black community. We go deep south St. Louis, where many of our poor white counterparts live. Those hospitals are also closed. There are at least 3 hospitals closed that I passed last week. So how can we make changes if we don't acknowledge the impact of what's going on around us? So racialization is another term that is also often used when we think about the context of studying race and disparities, and especially those that are impacted by the black community. So the Human Genome Project recognized that there are genetic characteristics that exist, and many of those characteristics exist based on our ancestry, which is not race, right? But there is also the predisposition that some groups, based on the social construct of race, experience more disparities. I've given you all a few examples already. For instance, we are often characterized by how we look, so by how we wear our hair, the color of our skin, our facial features, and other attributes that make us who we are in terms of our outward appearance, without thinking about what is also going on in terms of our ability to receive the care that we need. Moreover, racialized groups often have different experience that relate to transgenerational experiences, like the history of slavery, the histories of immigration, and even current immigration, genocide, and the acculturation that we have, and assimilation that many of us have to do that are people of color in order to receive the things that we need to be healthy. And so all of that impacts us globally. I know that this is small, but I really like this paper. There was a framework that looked at the structural racism and discrimination of ADRD, and they compared what they called hospital and public health interdisciplinary research, which is HAPI, and HIT, which is the health information technology. And the authors had a definition of structural racism and discrimination as macro level conditions conditions that impact opportunities as well as resources, which are based on levels of privilege. So those that live in areas that have lower level of privilege, either based on our race, based on racism, or even based on social constructs or the ability to go to the hospital because one is 2 minutes from you versus having to go 20 minutes away. And so thinking about the historical impacts of structural racism and discrimination and how that's impacted all of us. So it goes back to the policies, which are institutional in nature many times, so residential segregation, segregated schools, and even thinking about the social determinants of health related to our ability to work in areas that we need, our education level, having transportation, housing, and even the built environment and the community's capacity. And it also goes back to thinking about the system level barriers to health care, so access to quality and timely health care as well. And then they do provide a few examples in this paper as well. And then they also are thinking about the intermediary discriminants as well, those that are interpersonal to us and intrapersonal as well. And so we think about all of these factors, and we go back to the Alzheimer's disease report, their facts and figure report, and we can see here when we think about access to healthcare providers who understand race and ethnicity, we can see that African Americans, as well as our Hispanic counterparts, feel that it is important for Alzheimer's disease and dementia healthcare to understand race and ethnicity and the person's backgrounds. But they are not as confident that they will understand this as well. So it is important for us to think about interpersonal and institutional racism and how that impacts us. There are multiple studies in this space which evaluate the interpersonal and the personal experience with institutional racism, as well as structural racism, where Blacks often mention that we have more experiences in these spaces. And our lifetime experiences with racism impact our cognitive health. And even in one study that was done, looked at persons that were 90 years of age and older, found out those that had more experience with racism had more concerns with their cognitive health. So what about St. Louis? So St. Louis, we've experienced delays in diagnosis. We have a paper that's coming out that's looking at that now. It's still embargoed. Suzanne Schindler is the first author of that paper. We found that there were delays in diagnosis and access to our memory and aging clinic, with Blacks and whites being able to, I know I have to stop, so just humor me for 1 second, please. And so we know that is impacts whether or not one has the ability to receive the care that they need. So we know that prejudice is the burden of the past, it threatens our future, and it renders the present inaccessible. And I will leave you with that. Thank you so much.
All right. Question or two? Yeah. Introduce yourself as well.
Oh, I'm Dr. Riley. I just want to know, you have a printout of all the medication that you have for so long?
What did you say?
Do you have a printout or?
Yeah, we will.
It's available on our website with permission of the speakers.
Mm-hmm. We can share the slides, and I'm wondering, Mark, if we should just stop the slides where they are, since I didn't go through the other ones, because it seems like.
Well, we can put anything up.
Yeah. So yes, I'm happy to share my slides.
Great.
And I can even, if you like, Mark, do you want me to share some of the articles that were referenced? We can do that as well.
We'll put everything anybody wants on the webpage, so it'll all be accessible afterwards.
Okay.
Any other questions? We'll take one more. Okay. Well, thank you very much.
Thank you so much.